My name is Dr. Kip Webb. As you can see from the title slide of my presentation, I have a set of initials behind my name. One of them is my medical degree. The other is a background in public health. I will admit at the beginning of this presentation that the public health side of my brain has taken over. In addition, I'm a patient. In 2001, I was diagnosed with cancer. And I'm happy to tell you that that disease is in my rearview mirror. But that experience of having had cancer really changed the way that I think about healthcare delivery. And so it really is my pleasure to be here today in Oslo to talk to you about a new future patient-centric world of healthcare. And I'm asking the questions, what is it that patients want? And additionally, what are providers going to need in order to provide that kind of care? My talk is divided up roughly into 4 different sections. The first section sets the context for why we need to change the way that we deliver healthcare. The second section tries to answer the question, what is it that patients are looking for? And I will tip you off that I don't have the answer, but I actually have some guidance that I think may be helpful as you conceive of the future system. The third section says what are the kinds of information technology tools that might benefit both doctors and patients as we move forward to create this system. And in the fourth section, I'm going to put it all together with some real-world examples of organizations that have accomplished this. In this first slide, what I'm showing you is the high cost of healthcare and how it's not evenly distributed across a population. The data in this slide, of course, comes from the United States, but I've shown this slide all over the world, and it always gets heads nodding up and down saying we're seeing the same thing in this country. What you see in this slide is, roughly speaking, about 30% of the $2.5 trillion that we spend in America on healthcare each year gets spent on 1% of the population. In the next 9% of the population, we spend an additional 40%. So in other words, 70% of our healthcare expenses are being delivered to only 10% of the population. The important take-home message from this slide is that if we can change the way that we provide healthcare to that top 10%, we can make a significant dent in the cost of healthcare in our countries. This next slide may be a little less intuitive to you. It does that every time. I don't know what's going on. But it may be a little bit less intuitive to you. So I'm going to explain what this slide shows. On the bottom axis, down here, we have cost and increasing cost. On this axis, we have benefits. And what you can see in this curve is the healthcare industry today. And what that curve is telling you is that sometimes we deliver care that has a benefit. Sometimes we deliver care that has no benefit at all. And then, most damningly, there are times where we deliver care that actually causes harm to patients. An example of overuse or waste would be duplication of lab tests or radiology exams, or using medications or performing surgical procedures that have been proven ineffective. An example of harm or misuse is when we're doing something that's contraindicated to patients, either because of allergies or comorbid conditions or some other problems that they may be having. What this slide is also telling you is that we don't do the good stuff as often as we should. There was a famous study published in the New England Journal of Medicine in 2003 that said we're practicing evidence-based medicine only about 55% of the time. I called the author last year and said, how are we doing? Surely we're doing better than that now. And she said, no, we're really not. It's only up to about 60%. Now, the reason that I show this slide is for the last 20 years we've had a debate in the United States that seems to indicate either I can lower the cost of healthcare or I can improve the quality of healthcare, but that you can't do both at the same time. What this slide is telling you is that it's absolutely possible to do them both at the same time, to both lower costs and to improve quality. Now, the way that you might do that is by creating a more patient-centric system. I'm reminded of the quote from Robert Kennedy when he said, "Some people look at the world and ask why. I dream things that never were and say, why not?" This is a slide that's really trying to echo that point. This is the state of healthcare today. And what you can see is we go through a cycle that is prevention, followed by diagnosis, followed by treatment, rehabilitation, and ultimately management. I highlighted intervention in green because in most countries around the world, and Norway would be an example as well, you spend most of your money on intervention. Now, what are the attributes of that kind of a healthcare system? You can see that it's healthcare that is centered around the needs of the system more than it is around the needs of the patient. It's a healthcare system that puts the role of the patient in a fairly passive role. It's episodic. It's fragmented. Well, what if we did it a little bit differently? You can see that the elements of care are exactly the same, but what I'm suggesting is that we can move the investment in care upstream. And we spend relatively more money in prevention and in diagnosis and being more patient-centric. Well, what would we need to do that? We'd need to create a system that really treats the patients holistically, that enables them to take better care of themselves, echoing a theme that the previous speaker talked about. So that's the future. That's the future. So, what is it that patients want in trying to establish that future? And as I said, I don't really have the answers. But there are a couple of important points that I'm going to cover in the next 3 slides. The first point in this slide is that not all patients are the same. In this table, what I'm following is generations of patients over time, and the way that they seek information, in the way that they interact with their healthcare environment. And I'm just going to point to 2 examples of this. The first example are the most elderly in our population, what they call the greatest generation, or those patients born before 1945. What you can see is that they're very loyal in their personality, both loyal to their doctors and to their hospitals. They like a chain of command. They like the paternalistic tone where the doctor tells patients what to do. And then finally, they like an information style that's very direct, face-to-face, doctors interacting with patients. Contrast that with the millennials, or the Generation Y patients. What they're looking for is distinctly different. What they look for is something that's much more collaborative in the way that they're communicating with one another. Think about social networking as an example of that. And the information style that they have is also much more connected. Where they're bringing data to the doctor, they want to have a conversation about what's best for them. The doctor may know what's best and proven in the medical evidence, but the patient knows what they're most likely to be compliant with. It's important to think about this as we're designing hospitals and healthcare delivery systems going forward, because we need to be able to treat both kinds of patients. Particularly as we're making big investments in new hospitals or ICT systems, we really need to be designing them towards the future, because these millennials, while they're not sick now, will inevitably become patients one day. This next slide, I actually find quite shocking. And what the data on this slide is it comes from Quintiles, which is a research organization. And it asked patients, in your own words, how would you define value in healthcare? Now let's step back and think about that. How do we define value when we buy a new car? Well, we look for the best quality at the best price. How do we buy a new flat-screen television set? We look for value, quality over price. Well, now let's think about patients and the way they view value in healthcare. What you can see is that the majority said, I'm not sure what it is, but it's neither outcomes, which is quality, or cost. So in other words, the two metrics by which we make other consumer decisions, most patients are saying don't apply to healthcare, which I think is shocking. Notice that the number 3 answer was cost. Notice that for doctors, the number 1 answer was cost. So what's that telling you? It's telling you that quality is assumed, that I am going to get the same quality no matter what care setting I get into, and that patients very much believe that, doctors believe that as well. What I think this slide is telling you is we need to do a better job helping patients make good consumer decisions. I don't know if there are anybody here from Sweden, but Sweden just passed a law which gives patients choice for the first time. This is going to be very important as we're making them healthcare consumers with choice to empower them with the tools to make good choices. The last point that I want to make is on healthcare megatrends, IT megatrends, and say, how do they apply to healthcare? And what you can see is that there are 4 big megatrends that we see. The first one is visual, that today's citizens are really looking for a much more visual interaction with the world. This is how they're getting and processing information. Think about the rise of YouTube as a nice example of that. And the data on the far right-hand side of this slide is telling you that by 2014, every second, 2 years worth of video data will be loaded up onto the internet. Every second. It's extraordinary. Second point is they want it personalized. So I'm using the example here of cell phones and the abundance of cell phones in the society, even developing nation society, perhaps most particularly in developing nations, and saying how can we use cell phone technology to help personalize medicine? But overall, how can we personalize a lot of the consumptive decisions that patients are going to make? Next one is social. And I mentioned this in the last slide, is that they want interaction. They want a community of people who are like them in managing their various wellness states or disease states. I think about the rise of websites like 23andMe or Patients Like Me, which set up these communities of patients who have similar conditions. And then the last one is that they want it augmented. Static hospitals with signage and stuff like that is not enough. We're going to need to augment the experience. Now, why am I presenting this slide? What's important? For the hospital administrators out in the audience, what's going to be important is as you want to compete for these patients over time, as you want to draw them into your facilities, paying attention to these 4 megatrends is probably going to be important because they're getting this very satisfying experience elsewhere in their lives. They're going to expect this kind of experience from their healthcare environment as well. So now I'm going to shift gears and talk about the role of information technology. And I just have 3 slides that are going to address this. And this slide really is trying to answer the question, does healthcare IT help? Does it help us to deliver better care? What you see on the far left-hand side of this slide is a number of attributes of care delivery. For example, access, preventative care services, and then all the way down to, at the bottom, to effectiveness of care and efficiency of care delivery. What you then see spread out over the graphic is the green bars are that the literature shows a favorable outcome in that area. The blue bars says it's a mixed positive outcome. The yellow bars say it's neutral. It neither showed nor a benefit nor harm. And the red bars showed that actually IT maybe was a little harmful. What you can see at first blush is that the majority of studies show a lot of green. It shows a lot of beneficial outcomes that are attributable to healthcare IT. But you also notice that it's not universal. And you'll also notice that the place where it is the least positive is actually in provider satisfaction. That we need to provide our physicians and nurses with better tools such that they can improve the care that they're taking of patients. I know that's very true in countries like Norway and in Denmark, where they have high penetration and adoption of electronic medical records, But the providers don't like the tools they have very much. They don't like the medical records that they're using. Now, why might that be the case? This slide actually comes from the Health Information and Management Systems Society, or HIMSS. And what HIMSS has done is looked at all of the hospitals in the United States and said, how much IT are they using? At the bottom side of this slide, it's that they're not using IT at all. And at the high end of this slide is that they're highly interconnected and using IT systems for almost everything. What's interesting about this slide is that at HIMSS Stage 4, we're starting to use real physician-facing applications, which are shaping the way physicians are making decisions about the healthcare that they deliver. And what you'll notice, and this is data that just was published last month, that only 25% of U.S. hospitals are Stage 4 or higher. 75% are Stage 3 and lower. Now, the reason that that's important comes in what kinds of benefits might you expect to achieve depending on how mature your IT systems are. And at the lower end of the stack, and I'll use the example of Stage 1, which is where you have a lab system and a radiology system and a pharmacy system installed, the benefit you might expect to see is reduced duplication of tests. I'm not going to order the lab test today because I can see the result of the lab test that was performed last week. Same thing with a chest x-ray. Those are good benefits, but they're not great benefits. Contrast that with CPOE, or computerized physician order entry. Here what I can do is eliminate handwriting mistakes, which are transcription errors. I can also shape the way doctors are choosing the medications that they're supplying, and that's eliminating prescription errors. If you go above that to closed-loop medication management, now I'm eliminating medication administration errors. And up at Stage 6 and Stage 7, I'm really able to transform care. This is an explanation as to why you're not universally seeing benefits from healthcare IT. A lot of health systems have IT systems that are too immature. I had a number of conversations in Norway yesterday, and the basic tenor of those conversations was our system is at about HIMSS level 2. So in other words, I wouldn't expect that Norway would see a lot of benefits to date from the healthcare IT systems they have installed. The last slide that I want to touch on with healthcare IT before putting it all together is I get questions all the time of should I use an integrated electronic medical record, or should I try to connect all of the medical records that I have throughout the country already. And that's what I'm calling health information exchange. In this country, you might call it an EHR. It's a nomenclature difference. It's not an either-or choice. I think it's a both choice. Now, the advantage of using a health information exchange approach is that it's relatively low cost. And if your physicians, if your care providers really like the tools that they're using, connecting those tools is probably a very good idea. But what if your doctors don't like the tools they're using? What if the doctors feel that they're not supporting their workflows, if it's not helping them to take better care of patients? Then I think abandoning the EMRs that you currently have in favor of something that's more integrated might make sense. Now, the con of that is that it's expensive. That's a big decision. It takes time. It takes a big concerted national effort in order to do that in the long run. But I think the benefits can be proven. Which brings me to the closing comments of my presentation, which is putting it all together. The futurist William Gibson said, "The future is now. It's just not evenly distributed." And what I'm going to talk about here is two examples of organizations that have created exactly the future that I've been talking about. I'm not going to talk about Kaiser Permanente, because you've all heard about Kaiser Permanente. I could talk about them quite a bit. They've done a remarkable job. But I've chosen to talk about two other organizations, just as proof that organizations besides Kaiser Permanente have been able to achieve this. The first group that I'm going to talk about is the Group Health Cooperative, which is based up in the Seattle, Washington area in the northwest corner of the United States. Group Health Cooperative manages approximately 600,000 patients, roughly the population of Oslo. What they decided a few years ago was that they would use their electronic medical record to support a new model of care delivery called the patient-centered medical home. Now, the patient-centered medical home is not a concept that is familiar to most people, so I'm going to take a moment to explain it. What it does is it says, instead of a doctor having several one-to-one interactions every single day, how can we use that doctor to actually manage the care using a team of healthcare delivery people? Sometimes it's the doctor in a traditional one-to-one office visit. But in other cases, it might be using nutritionists or health educators or shot clinics or support groups for patients who are dealing with a common set of diseases and might be much more efficiently managed than in a one-to-one setting. Well, now, in order to try to change to that kind of model, you need to make an upfront investment. You're now asking the doctor to both see patients and to manage a care delivery team. And so Group Health Cooperative invested up front. They hired more doctors. They introduced new processes of care delivery. They promoted this among their patients. And what you're seeing up on this slide is their results 2 years into the program. 2 years into the program, they had reduced emergency room visits by almost 30%. They had reduced hospitalizations by 6%. They got savings of approximately $40 million over the population that they were serving. And they had a return on their investment. And remember, their investment was hiring more doctors and changing processes. They got a return on investment of 50% just 2 years into the program. They also got something that I'm not showing on this slide, was dramatically increased physician satisfaction and dramatically increased patient satisfaction. I think that this is a wild success. I'm now going to shift gears and talk about one other organization. And this is the Geisinger Health System. And Geisinger is in the state of Pennsylvania. And Pennsylvania, for those of you who know the state, it's on the eastern part of the United States. And it's a big, sort of long, thin state with the city of Philadelphia in the east and the city of Pittsburgh in the west and very rural area in the middle. That rural area comprises about 2.2 million people. It's coal mining country. The rates of obesity are 70% and up. There's a high degree of smoking and chronic lung disease and heart disease. This is not a healthy population of patients, but this is the population that Geisinger serves. And they decided that they too would establish a patient-centered medical home. What I'm showing on this slide is process of care outcomes. And what you see is blue is before, red is after, for a variety of different processes. Diabetes care, management of coronary artery disease, management of heart failure, management of high cholesterol. And what you'll notice is those bars all go up. We got better. We were doing more of the right things with patients that we should be doing. But I want to show you this slide and say, what else did they do? And what they did was they lowered risk-adjusted hospitalization rates dramatically in their area. Now, this is looking at Medicare patients, and Medicare patients in the United States are, for the most part, patients over the age of 65, so the elderly. I've already mentioned that this is a fairly sickly population. And what you'll notice is that when they began, they had a hospitalization rate of approximately 350 per thousand per year. What you'll see is they rolled out the program in phase 1. This is each year as they moved forward, so it's 4 years worth of data. Every year they lowered the hospitalization rate with a cumulative effect of lowering hospitalization rates by about 35%. The program was so successful, they rolled it out to additional facilities who have demonstrated similar responses. Here we have a control group of hospitals where the program wasn't rolled out, and you can see hospitalization rates stay very high. I'm not showing it in this slide, but they also lowered hospital readmission rates. which in the Medicare population in the United States average about 30%. They were able to lower hospital readmission rates by 35 to 40% across the board. So we're taking better care of patients. We're keeping them from winding up in the hospital, and we're keeping them from being readmitted to the hospital, according to this Geisinger data. I now want to wrap up and say, if we're going to move forward to a patient-centric world, what are the things that we're going to need beyond EMRs and beyond health information exchange? Well, the first thing is you need the data. You need to be able to transmit the data such that both doctors and patients can make better decisions. In the second bullet, it's really saying you also need those human factors. You need leadership. You need a commitment to change, a commitment to new healthcare delivery models. And then the final bullet is telling you what other technologies might you need. And you need great analytic capabilities to measure, monitor, and improve over time. Those are all my comments for today. The future is now. I'm very excited about a patient-centric healthcare system in the future, and I hope that you are too. Thank you very much.